And then we're going to give me time while you take a break. I'm going to load the blood disorder. Okay, so make sure that you know that in the although the title here is acute respiratory distress syndrome, but this is what as a result of the microvascular injury that leads to pulmonary edema. And the steps are that the first thing that you see is that you have alveolar cells injury, then you get an inflammation response, and the results of inflammation response, you're going to get edema, particularly type that has a lot of protein, exudate, and that's going to form a gel-like membrane that leads to further exacerbation, so that gases exchange between oxygen loading and CO2 unloading is defective, and so the person may in the case of COVID-19, then they cannot breathe, and therefore you need a ventilator. All right. So if you look at H&E staining of the lung, you can see here, this is the gel-like protein right here. Okay, and protein will be oftentimes seen as very eosinophilic staining, so it looks like rest like this. Okay, you get a lot of inflammatory response. We don't know what initially causes this. It could be a person, dying from by smoking inhalation, or they're drowning. So water is supposed to goes into the esophagus, but cannot breathe, and it opens up, so the water can get drained down into the larynx and the tracheas and into the lung. And once you get in the waters in the lung, it's hard to move that water out. Okay, that can lead to that injury of the alveolar cell, which is the first thing that you see. Okay, again, it shows you that you would see this protein accumulations in the alveolus, the intraalveolar edema. Okay, again, this is part of the quiz, but make sure you know that the 4 causes of obstructive lung disease are emphysema, bronchiectasis, you see here, chronic bronchitis, and asthma. I would say that emphysema is often associated with smoking, and progressively, smoker, you damage the alveolar membrane. So typically, inhalation is an active process, but exhalation is a passive process, and that is because if this lung is inflated, right, it'll be like that. Okay, and the elastic tissue in this membrane right here, if it's expand, right, it's going to recoil. It's going to recoil, and so it's going to come back that way. Okay. Now, in the case of emphysema, what happened is that they lose this membrane, so they're going to be, I say, like that, and when it's inflated, it'll be like that. But you don't have, normally you will have a membrane here that help it to recoil, right? To deflate it, if you will, so air can go out. But you don't have that now. This has disappeared, right? So then air is blocked for breathing comes out. And so then if you want the air to go out, you have to squeeze. You really have to squeeze this, right? So that causes air to go out, for example. So emphysema is due to the loss of this alveolar, or these membrane, if you will, respiratory membrane. Chronic bronchitis is basically you get a lot of inflammations in there. And if you look at the relationship between these two is that some people may have just purely emphysema, some people might have purely bronchitis, but most people will have two. Bronchitis is basically a lot of immune there. Although we don't know what causes this yet, but some people, especially children, develop asthma. It's just some maybe severe allergic reaction to something. We don't know what triggers of it, but their airway is also blocked. As such, if the airway is blocked, it makes it hard to air goes out, right? So we call that obstructive lung disease. Bronchiectasis, we already saw as part of atelectasis, which means that you get a lot of mucus productions, right? Especially, again, after post-surgery, and you cannot move that mucus, and then air is just blocked from going, and the remaining air is going to get absorbed, so it's called resorption. Okay, and here is asthma. Oftentimes we can see is that the lumen is narrower than it's normal. If there's an allergic reaction, you might take an inhaler. It would be called bronchodilator to open up this. Because then if this if this lumen is constricted, then it's harder to breathe. You feel like you're suffocating. You also see a lot of mucus production, a lot of inflammatory response. You can see that. So the fourth thing that are associated with obstructive lung disease are SIBA. Okay, that's how I remember it, which is chronic bronchitis, emphysema, bronchiectasis, and asthma, SIBA. And here I'll show you the SIBA. So you can see here is it doesn't have bronchiectasis, but if these are signs and symptoms that are associated with asthma, and these are signs and symptoms associated with chronic bronchitis, and this is a sign and symptom that is associated with asthma. They're very similar in a way, but have different feature. And there is a common, in this Venn diagram here, on all of them is that, collectively they'll call them chronic obstructive pulmonary disease or COPD, but this is also obstructive lung disease because it's interfere with the ventilation, air going out. And so the person has a problem. Therefore, in this case, remember again, right? So the FEV1, if it's obstructive, FEV1 over FVC in this individual is less than 80%. And so they have a hard time pushing the air out. You can take in air normally, but blowing it out with difficulty, right? So we're gonna say that 1 second here, instead of like this, it'll be like this. All right. Very, very low within that 1 second. Okay. Here's what you see is that in case of some emphysema patient, they will have bronchitis. Some of the bronchitis people will have emphysema as well. It's not one or the other. Let me go back to that another one, and you can see here is that there's a relationship here. There's a relationship between emphysema and chronic bronchitis. And you can see his patient with chronic bronchitis, right? Not a lot of alveolar wall destruction, but in the case of the emphysema, you get a lot of bronchial alveolar wall obstruction. So most people with COPDs right here, they have chronic bronchitis, and they also have alveolar wall destruction. Also a very good term to note, which is basically is define them as either pink puffer or here, okay, pink puffer or blue bloater. So good, remember to easily remember them as pink puffer begin with P and P. Emphysema has P's in there. Blue bloater is B and B, and then notice that chronic bronchitis also have B. This is just usually the old term describing a person who typically skinny, right? And their skin is actually looks like pink, and they usually have pursed lip too. Look this, and they're breathing. Actually, the pink puffer. Um, they have a shortness of breath, and oftentimes they breathe faster rate. Okay. Whereas the blue bloater, so this is also related to if you look at the chest, it's more like barrel-shaped chest. So the barrel-shaped chest is like that. There's a question. We don't have this slide. Okay, then write it down. Pink puffer emphysema, blue bloater bronchitis. So good thing to know, P and P, okay? P and P. Pink puffer emphysema, blue bloater bronchitis. And just, I think you can Google this. It just shows you that this guy also, for the blue bloater, they tend to be more obese, whereas the pink puffer tend to be skinny. Okay. How would you describe this guy? Skinny, pink puffer, skinny. Yeah. Barrel chest. Okay. Have barrel. And he tends to be more red. His skin tends to be more red. Right? So that's why they call pink. 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 And pursed lip, and breathing faster rate. Blue bloater, on the other hand, the skin is look like blue, just getting not enough getting oxygen. Okay, blue, and he tend to be overweight. Okay, he tend to be overweight. And he also have, both of them have shortness of breath. That's not. I would say that with this guy also have chronic coughing as well. Okay, so here with the blue bloaters you get chronic coughing. Okay, sorry. All right, so can we move on? By the way, next time if you want to ask what signs and symptom is, that's SNS. That's the short handwriting for SNS. That were the signs and symptoms. Emphysema, you can see here. I showed you that emphysema, someone has barrel-shaped chest, and oftentimes from a smoker that you see this. In the case of emphysema smoker, this is trying to show you that microscopically, this membrane, you lose that membrane, and you can see here, and so air get trapped. The other way that people can also look at in terms of capacity, and not only is FVC1 over FVC, right? In the emphysema is part of obstructive lung disease. Again, not only does FEV1 over FVC is less than 80%, but if you want to look at the residual volume, right? So residual volume will be increased as well. So normal lung residual volume might be 1200 ml. Okay, that's just a normal number. But in this case, you get all that air that get trapped, all the air that get trapped in here. So the residual volume that go up to, say, for example, 1600 to like 1800 ml. So it's staying in there, it stays in the lungs. So that's why the lung gets so big. And you have to work at it to push that air out. Okay. This is basically scanning electron micrograph to show you that there is the alveolus is really, it should be really small, like this size right here. But because they're losing the membranes and they typically become larger than normal, you see that? But microscopically or even electron micrograph to show you that. All right, so then the relationship between emphysema, which is alveolar wall destruction, and chronic bronchitis is inflammation. Okay, inflammation. Bronchiectasis, this is often associated with post-surgery, a lot of mucus production, but you know what else is also related to? It's related to cystic fibrosis. Okay. So we call this CF patients. CF patient is often sees this in children, okay? And they have a defective, you can say, let me write this down, defective chloride channel. So your cell have chloride channel just like you have, sodium channel. So, typically every cell, right? Intracellularly, you have high concentrations of potassium. It's very high inside the cell. And concentration of sodium is very high outside the cell. Like this. And wherever there's high, there's also high chloride channel as well. Right? High. So, if you look at your blood, your sodium level is about 142 milliequivalent, 140 per liter, for example. Chloride is near there, it's about 120 or something like that. It's very close, very high. But normal cells has a typical way to take in chloride and to remove this chloride. So children who has a defective chloride channel, defective chloride channel, right? They cannot move the chloride. So then, if you look at their sweat gland, for example, it's very salty. And this disease known as cystic fibrosis is known for many years, hundreds of years. In fact, there's an old German saying that, blessed is a child who, if you kiss in the forehead and the eyebrow taste salty, for the child is sure to going to die. Meaning that they already know that the sweat gland is very salty. I mean, they cannot move chloride as much. Oftentimes they have problem with the GI tract. You cannot move micro pancreatic secretion. They cannot, in the lungs, they cannot move the mucus, for example. So, and they tend to get a lot of bacterial infection. And the common bacterial infection that is associated with this is Pseudomonas. Okay. Pseudomonas is a common bacterial infection associated with this CF patient. Okay. As you can see here just tells you that a genetic disorder affected the lungs, but also the pancreas, liver, kidney, intestine. And then the long-term issue is difficulty to cough off the sputum. That you can see that it's defected in the gene called CFTF. It's chloride ion channel, which pretty much you can do the sweat test to see that the patient have it. And the chronic infections of these CF, what you see is that typically Pseudomonas is present. So if I have, when you see the question that has Pseudomonas in there, most likely it's often associated with CF. Okay. Bronchiectasis, we already talked about that already. Restrictive lung disease. So in restrictive lung disease, FEV1 over FVC is normal. Okay, so in other words, it's greater than 80%. They have no problem take in the air and blow out 80% of that within the first second. They do, however, the amount of air they take in is not as normal, right? So when most people vital capacity is supposed to be 4.7 liter, and their vital capacity is, let's say 3 liter. Okay, 3.0 liters. So it's much lower than this, right? So we call that restrictive lung disease. And you can see here, there's normal. Some of them are idiopathic. We don't know it. It could be related to inflammation related to fungal infection, very common in immunosuppressed individual. And what you see is that is common also in asbestosis that you can see there. Sarcoidosis is a very common one. So the 4 diseases that are often associated with restrictive lung disease are ACE, if you want. That's how I remember. So this A is asbestosis. Okay. A is asbestosis, which means they're inhaling these asbestos. Sarcoidosis, you can see here, it's inflammatory response of, sarcoidosis. It's very similar to, you can say, too much inflammatory response. In this case, it could be, say, TB, for example. You have granuloma, could lead to restrictive lung disease, and also the last one is known as fibrosis. Okay. All right, so these are the things that may cause now known as inflammation. Okay, great. Okay. So those are the conditions of restrictive lung disease. And you can see you can have here the fibrosis that you see is often in the interstitial, of course, but it can be in the alveolus as well. But most of the time it's interstitial, and you can see here, right, in the interstitium here, there's a lot of immune cells, right? So they're crowding out, if you will. They take up the space. So then the volume of air that you're taking in is lower than normal. Okay. Asbestosis is typically, I wouldn't be surprised after 9/11 that many of the firefighter or the first responder, when they reaches the scene, while they might have masks, but they can inhaling a lot of these particles that later on that could develop to give you lung disease. And many of them do develop what we call it mesothelioma, which is really a cancer of the pleural membrane. Okay, but just because you're inhaling a lot of those particles, that become triggers, causes cells to divide. In this case, asbestos used to be part of the insulation, and they put it in these walls for for insulating the house, but they don't use that anymore. In the old buildings, old school, they have asbestos. In fact, our school has some asbestos in the basement, and these guys trying to remove that. And they didn't know earlier, but if you inhale those, that could lead to, in case of cancer. In fact, the common cancer that I would say that is associated with asbestos is mesothelioma. Okay, that's also good to know. The common cause of um, cancer that arise from asbestosis is mesothelioma, okay, which means cancer of the pleural membrane. The pleural membrane is the membrane surrounding the lung. Okay. Vascular and circular lung disease, I think we already know that, um, you know, um, if there is an increase in pulmonary pressure, we call this pulmonary hypertension, right? Uh, Now, the blood vessels in the lung themselves, right? The difference between this blood vessel, for example, versus this blood vessel, like this. Oftentimes, what you see is that the lumen is small, but this is the wall of the blood vessel. Okay, it's kind of like an onion skin. So it's a thickening of the blood vessel wall that goes in the lung. Uh, when you see that, that's indicative that there is an increase in pulmonary pressure. So it's smooth muscle, right? If something is causing it to work harder, it's going to increase, in this case, number of cells. All right. So pulmonary thromboembolism typically, and that is very common. The most common causes of an embolism is from a thrombus that is developed in, we'll call it deep vein thrombosis. Okay. Deep vein thrombosis. And then that deep vein thrombosis is usually finds in the leg, and they move to the lung, and they get stuck, for example, in the lung. And because, of course, blood pressure and pulmonary artery increase, then less blood goes into the lung. Lung cannot work very well as well. Ultimately, the right-hand side heart failure, as you will. And every time when you see right-hand side heart failure, distended neck, right? Enlarged liver, enlarged spleen, and so forth. Okay. Pulmonary hypertension often is irreversible and fatal. So it's narrowing of the pulmonary artery, right side heart failure. Normal pressure is 50 millimeter mercury. If it goes to 25 millimeters mercury, just 10 more millimeters different can cause this a deadly serious consequences. But the key hallmark too is this, right? So my clue to you is that when you look at the here, the histology of the person who has pulmonary hypertension is that the alveolar right here, arterial, will get kind of like an onion. There's a hypoplastic endothelium lesion. Next time we'll see similar thing as well called malignant nephrosis. And this is the case that you often see if there is too much blood pressure that goes to the kidney. Okay, malignant nephrosis, for example. All right, so going back, this is deep vein thrombosis, pulmonary thromboembolism, infarct leads to dead tissue. This we consider as red infarct because it's more like soft tissue. And I think I wrote down a question regarding the thrombus in the exam 2, but you might see the similar exam 3, and that is a deep vein thrombosis develops in the leg and it moves to the lung. Okay. That leads to pulmonary hypertension. Okay. Cor pulmonale is the term that I use. That basically the right hand side will be enlarged due to um, uh, the right heart is working harder. Okay. So the term cor pulmonale is a condition, is defined as a condition that causes the right hand side heart failure, okay, right heart to fail. And long-term high blood pressures and arterials to the lung, right ventricle heart, it leads to what we consider as cor pulmonale, right? So right hand side heart failure, low blood oxygen level to the blood. Now, in a way, these two is kind of similar, and that is cor pulmonale and Eisenmeyer's syndrome. We talked about earlier. Both of these has, in a way, kind of a very similar sign, and that is there is an enlarged right ventricular wall. There's a large right ventricular wall. But this is due to pulmonary hypertension, right? Due to a blockage in the arteriole from deep vein thrombosis that has been that have moved to the lung. Eisenmeyer syndrome is we saw the genital effect, right? Remember talking about the right to left shunt or left to right shunt. Most of the time it's left to right shunt, okay? And because the left side has higher pressure, you only can get initially left to right shunt and right to left shunt if you have the left hand side heart failure. Then you have an increases resistance to the lung, then it can lead to that Eisenmeyer syndrome. So here, Eisenmeyer syndrome refers to this congenital heart defect, intracardiac communication, that leads to pulmonary hypertension, reverse flow, and cyanosis. Okay, so also very good to note too, that whenever you look at your note, right to left, right to left shunt. This is related to the 3D. No, the truncus, the three teeth, right? T. Right, left, because if there's a right to left shunt, there aren't very many blood going into the lung. So you're going to see a lot of deoxygenated bloods in the lung. Therefore, you're going to get cyanosis. Okay. Now, in the left to right shunt, that is often related to the D, like the ductus arteriosus, the atrial septum defect or ventricular septum defect, right? Here is left to right. And the right to left is the three T's, like tetralogy of Fallot, transpositions of the vessel, or truncus arteriosus. Okay, that's a 3T. And that T is associated with cyanosis. Whereas here, left to right, there is already oxygenated blood from the left-hand side. If it goes to the lung and it goes to the right-hand side, it goes to the lung, it just means that there's more oxygenated, again, going to the lung. So in this case, left to right shunt, you have no cyanosis. And that's how you can tell between left to right and right to left. And that here there is no cyanosis. Cyanosis means that you get that nice purplish around the lip, for example, or the skin, or the extremity. Right? Eisenmeyer syndrome, we are talking about left to right shunt, over time become right left shunt. Okay, you can read that. Pneumonia. Okay, so a couple of things that we can talk about pneumonia. We don't have that slide. You don't have what slide? You don't have this slide, Eisenhower syndrome slide? All right. Okay. I'll put this up for you guys. Okay. But it tells you the same thing that I discussed with you already, which is congenital defect, left to right shunt, later become right to left shunt because the right ventricular wall is thicker than normal. Very similar to corpinal, but the consequence might be the same. Increases the thickness of the interventricular, increase in the ventricular wall on the right hand side. But we come from different things. One is basically blockage of the artery, and the other one's due to left hand side heart failure that leads to fluid retentions in the lung, pulmonary edema. Okay, so someone remind me to send you that slide regarding the and the blue bloater. So I have to do those two. Okay, so blue bloater and the what was the other one? Core pulmonale. All right. Pneumonia, typical terms used to say inflammations of the lung is pneumonia. Right? COVID-19 can lead to inflammations in the lungs known as pneumonia, fluids accumulation. Okay. The and for many years, that people get pneumonia is from getting infection from Streptococcus pneumoniae. Okay, so the most common cause, let me put it this way, in the community acquired pneumonia, we call it CAP. Okay, the most common cause is Streptococcus pneumoniae. Okay. Now, there is, you know, sometimes you can also get into the hospital and you can get sick because you have acquired that from the hospital, nosocomial, right? And these nosocomial are these microorganisms. MRSA, which is methicillin-resistant Staphylococcus aureus, Pseudomonas, very common in the cystic fibrosis patient, Enterobacter, Serratia, for example, right? Now there is also another one that oftentimes people use, and which is they call it PAP. Right? Now PAP stands for primary atypical pneumonia. Pneumonia. Right. So the primary pneumonia caused community, that is Streptococcus. In the case of these atypical, in other words, you get pneumonia, but you look for the contact culture, you do not see Streptococcus. You do not see Streptococcus. But you get pneumonia. What do you call that? That's known as primary atypical pneumonia. And primary atypical pneumonia now is caused by an organism that is not culturable. Okay, so caused by organism that often is not culturable. In other words, you cannot detect it in any culture. Any culture, you're trying to find it, but it's not there. Okay, what it is that organism? Mycoplasma is one of those organism that is, it's very tiny, it's very small. It's a you know, um, it's a bacteria, but it's an intracellular one, interestingly, and it's very small, kind of very hard to culture. All right, so why don't we take a 5 minute break here? I'm going to stop the recording, and then we'll come back and see if we can finish the rest of it, and then start on the blood vessel. Let me see uh, how much more do I have? 44. Okay, not too bad. So it's the 52. All right, we're almost done. All right, I'm going to stop it here then.